Welcome to the fifth webinar in the PSC Partners 2020 Annual Conference Webinar Series, What's New in Pediatric PSC, COVID-19 Updates, Liver Transplant, and more. Thank you so much for joining us. My name is Mary Villas. I am the president of PSC Partners Seeking a Cure Canada, a Canadian registered charity and affiliate of PSC Partners Seeking a Cure. Prior to the emergence of COVID-19, we had all been looking forward to the 16th annual PSC Partners Patient Conference, originally scheduled for mid-April in Denver, Colorado. The annual conference is a highlight of my year and also for many in the PSC community as an opportunity to be together, to build community, and to support each other in person. The conference for many is a very important part of our toolkit of coping with life with PSC. I am a mom to a PSCer who was diagnosed as a pediatric patient. Attending our first conference, being able to attend sessions with specialists in pediatric PSC and meeting others with children walking this path was invaluable for me and for my family. And so it is with great pleasure that we bring you this virtual offering of this very important pediatric conference session. Okay, let's get started with two polls. Can we launch the first poll, please? So the question is, how old is the PSC patient? And the choices are under 5 years, 5 to 12 years, 13 to 17 years, 18 to 25, or 26 and older. Can we show the results? Okay, it looks like we've got almost 50% 13 to 17 years, so a bunch of teenagers. And then we've got the rest are sort of evenly spread between the other four categories, including some who are 26 years and older. Okay, great. Can we launch the next poll? So this question is, how long ago was the PSC patient diagnosed? Within the past year, 2 to 3 years ago, or more than 3 years ago? And it looks like most were, again, 57% more than 3 years ago, 29% within the last year, and just a couple 2 to 3 years ago. Okay, thank you so much for participating. And thank you again for joining us. Now to introduce the agenda, our panelists, and to kick off the webinar, CEO and founder of PSC Partners Seeking a Cure, Ricky Safer.
Thanks, Mary. I too would like to welcome all tonight's attendees to our Pediatric PSC webinar, which is part of our ongoing conference webinar series. Our past 4 webinars covering the basics of PSC, coping with PSC, and 2 sessions on PSC and COVID, mostly geared to adult PSC, have all been recorded and are accessible through our website if you missed them. We are scheduling future webinars as well as ongoing Zoom room support groups. Our next PSC patient Zoom room event will take place on September 1st, and our next caregiver event will take place on October 6th. We had hoped to hold our pediatric PSC webinar before schools reopen, and we are just under the wire. This meme probably mirrors your thoughts as you prepare your kids for the start of the school year. Our expert speakers tonight from Children's Hospital Colorado will cover what's new in PSC and pediatric liver transplant, as well as what's new in how to keep kids with liver disease safe during the COVID-19 epidemic and going back to school. Before introducing tonight's speakers, I'd like to personally congratulate them on their recent recognition in US News and World Report, where they were ranked #1 in the nation for pediatric gastroenterology and GI surgery, which includes hepatology and liver transplant. At PSC Partners, we are so proud of you. I'd like to thank tonight's speakers, our conference co-hosts, University of Colorado Health and Children's Hospital Colorado, as well as our other corporate sponsors, Gilead, Mirum, Intercept, Albareo, and Shire, for their support of our virtual conference series. Just a few reminders about upcoming programs where we will be relying on the participation of our PSC patients and caregivers. Our pediatric community plays an important role. Please save the date, October 23rd, in your calendar to join us for Making Our Voices Heard, the Patient-Focused Drug Development Forum. This is a one-time meeting approved by the FDA, and it's our big opportunity to shout out the PSC patient voice, our chance to tell our patients' stories, explain our symptoms and their impact on our lives, and also to identify priorities for future treatments. One of our panel discussions at the PFDD forum is strictly for pediatric PSC. So we need our pediatric patients and caregivers to participate in this virtual forum, which has the opportunity to become a game changer for PSC drug development. Much of the groundwork for this forum will be data that we are collecting currently in a patient caregiver survey. The more people who fill out this survey, the more valuable the data will be for researchers, drug developers, and the FDA. All information is de-identified. It will take just 30 minutes or less of your time, so if you're a patient or a caregiver, please go to the link on our website homepage to fill out the survey sometime within the next week. If possible, please fill out the survey via our registry, as it will have more impact. We're counting on the pediatric parents and kids. We have recently launched our updated PSC Partners patient registry, which is filled with new resources and features. We urge you to complete or update the registry clinical survey and explore the new interactive features of our registry. If all of us as patients and caregivers do our part as a community, we can display the true power of our patient voice. We welcome you all to join us. I have a polling question for our participants tonight. Could you please launch the question? The question is, what are your top 2 greatest concerns for the PSC patient? PSC disease progression, IBD symptoms, future transplant, living with PSC during COVID-19, or other? Please send in your answers. All right, looks like 74% of the people are most concerned about PSC disease progression. Next in line looks like future transplant, 37%, then living with PSC during COVID, and then IBD symptoms, and about 11% other. All right, thank you. Now I'd like to introduce our moderator, Dr. Dania Brigham, Assistant Professor of Pediatrics and Medical Informatics Officer in the Division of Gastroenterology, Hepatology, and Nutrition at the University of Colorado School of Medicine and Children's Hospital, Colorado. I'll turn it over to you now.
Thank you, Ricky. And first of all, thank you for PSC Partners for organizing this webinar and also allowing me to participate. I find that patients with PSC and their caregivers ask a lot of great questions, in part because there's so many topics to discuss and it becomes quite overwhelming trying to navigate the process from the time of diagnosis to managing PSC and possibly a transplant. I do think that this is a great opportunity to have their questions answered by our 3 experts from Children's Hospital Colorado, which was ranked #1 in the nation by US News and World Report for gastroenterology. So let me briefly introduce them and talk about the agenda this evening. Our first speaker will be Dr. Cara Mack. Second will be Dr. Shikha Sundaram, and last will be Dr. Juri Boguniewicz. Each speaker is going to speak for about 20 minutes. Then after all 3 presentations, we'll have about 25 to 30 minutes of your questions and answers, both from questions that were previously asked, as well as questions that you are asking live during this webinar. We ask that you please keep your questions general to try to help everybody rather than asking very specific questions about your own care. So let me introduce you to our first speaker tonight, Dr. Cara Mack. Dr. Mack is a professor of pediatrics in the Division of Gastroenterology and Hepatology, nationally renowned for her prolific research of various pediatric liver disease, including biliary atresia as well as PSC. She serves as chair of the Childhood Liver Disease Research Network PSC group, leading novel PSC research. She is the medical director of the Pediatric Liver Center, the program director for our GI and Liver Training Fellowship, and a very accomplished NIH-funded researcher. So without further ado, she's going to be discussing the updates on pediatric PSC. Dr. Mack?
Thank you, Dr. Brigham. And I'd like to thank PSC Partners for inviting me to speak. I'll be providing updates on pediatric PSC. Okay, so the topics we're going to cover are what causes PSC, what are the essential components to the diagnosis of PSC in children, are there markers that will predict progression or severity of PSC, and what are the current and potential future treatments for PSC. Next. Now, there are actually many factors that contribute to the cause or pathogenesis of PSC. One, there's a genetic predisposition, and to date, there's approximately 20 genes associated with PSC. Two, the gut-liver axis. We know that there's crosstalk between what's happening in the gut and the liver. And a couple of recent discoveries. One is that there's a unique microbiome in PSC patients whereby certain bacteria actually produce byproducts that travel to the liver and activate the immune system, leading to biliary injury. Another new discovery is that there are immune cells in the intestines that traffic into that liver and again activate various pathways of the immune response, leading to bile duct injury. Third, bile acids. We know in PSC that there's excessive retention of bile acids, and these bile acids can directly damage the lining of your bile ducts. Four, autoimmunity. There are multiple autoimmune responses occurring that directly target the bile ducts and the cells lining them. Five, fibrosis activation. There's evidence that there's aggressive or exaggerated fibrosis pathways leading to significant scarring. And all of these factors culminate together to produce number 6, cirrhosis, and the increased risk for cholangiocarcinoma. Next slide. So what are the essential components to diagnosing PSC in children? First, we obtain blood tests of liver function, as those shown here, and there'll be elevation of most of these liver tests at the time of diagnosis. We have found that in pediatric PSC, an elevated GGT is a sensitive marker for PSC. However, in adults, alkaline phosphatase is considered an accurate marker for the biliary disease. The reason that alkaline phosphatase is a less reliable marker in children is based on the fact that alkaline phosphatase also comes from bone. And during times of rapid growth, such as puberty, you will have an elevated total alkaline phosphatase level, but it's likely due to the bone and not the liver. Next slide. An MRCP is routinely performed in diagnosing PSC. On the left is a picture of a normal biliary tree. You can see the large sac-like gallbladder that is emptying into the tube-like structures of the biliary tree, and notice how smooth the edges are of the bile ducts. Compare that to a PSC patient on the right. The yellow arrows are pointing to the significantly narrowed or strictured parts of the biliary tree, and above those strictures, you will get dilations or swellings, and this is classic for medium and large duct PSC. Next slide. Now what if, a new very exciting research tool that we hope will come into clinical practice one day is known as the MRCP Plus from Perspectum Diagnostics. This is a tool that can accurately measure the size of the bile ducts as well as the number and the severity of the stricture. On the left is a normal biliary tree showing the intrahepatic small bile ducts in red, and they're approximately 1 to 3 millimeters. And then your larger common bile duct outside the liver is in yellow, and that's 4 to 6 millimeters. So that's what a normal biliary tree looks like. On the right-hand side is a patient with PSC, showing the baseline or MRCP plus at diagnosis in the top panel, and then 1-year follow-up in the lower panel. MRCP plus can very accurately quantify the number of strictures, the length of the strictures, and how narrow they are, what the actual diameter is. And as you can see here, the strictures are lighting up in red and the dilations in blue. And we think this is not only going to be a great tool at the time of diagnosis, but also a powerful tool to monitor progression of disease. But as I mentioned, this is still in the research phase. Next slide. Now, what if the MRCP is normal, but you still suspect that your patient has PSC? Then we recommend doing a liver biopsy to look for small duct PSC. Small duct PSC is much more common in children compared to adults. And what we're looking for is shown here. The yellow arrow is pointing to the bile duct inside the liver, and surrounding that you see this blue circular fibrosis or scarring. It's known as onion skinning, and that's classic for small duct PSC. Next slide. So another reason to consider liver biopsy is to look for a second autoimmune liver disease known as autoimmune hepatitis. And when you have autoimmune hepatitis and PSC together, that's known as overlap syndrome. Overlap syndrome, again, is much more common in children than adults, and up to 40% of children may have overlap syndrome. So we screen for autoimmune hepatitis with autoantibodies. And if any of those are positive, we'll proceed with the liver biopsy. And autoimmune hepatitis looks like what I've shown on the right there. I've outlined in black the inflammation that is inside that margin. And each of those little purple dots is actually an immune cell. And so this extensive florid inflammation inside that liver is very classic for autoimmune hepatitis. Next slide. Now, a new modality that we obtain after we have diagnosed PSC is known as FibroScan. FibroScan is a non-invasive measure of liver stiffness, and that liver stiffness reflects liver scarring or fibrosis. On the left is a picture of the FibroScan probe, and it's very similar to an ultrasound probe. On the right is the liver stiffness cutoffs in chronic liver diseases. The first row is showing you the actual FibroScan score that is generated and that your physician will see. The middle row is the histology score that correlates with that fibrosis score. So in other words, if there had been a biopsy, the degree of scarring based on that biopsy would correlate with a certain number of the FibroScan score. And the liver biopsy scores or stages range from F0, which is no scarring, to F4, which is cirrhosis. Next slide. So shown here is an example of how we use FibroScan. If your patient has a FibroScan score of 11, that would predict an F3 fibrosis if that patient had had a liver biopsy, and that's associated with severe fibrosis. Next slide. So moving on to our third topic, are there markers that predict progression or severity of PSC in children? And to answer this question, as well as others, Mark Deneau from the University of Utah created the Pediatric PSC Consortium. This is a worldwide network and database of PSC in children. Next slide. One of the first questions that he asked is, could GGT predict outcome? in pediatric PSC. And the outcomes that were measured are shown on the left. The poor outcomes that were analyzed were portal hypertension, defined as enlarged spleen, esophageal varices, or ascites. Biliary stricturing, requiring stenting or being hospitalized for cholangitis, was another poor outcome that was monitored. Liver transplant and cholangiocarcinoma. He then looked at all of those patients and divided them based on the fact of whether or not their GGT was less than 50 at 1 year after diagnosis or greater than 50 at 1 year after diagnosis, and then followed those children for up to 6 years. And what he found is that if your GGT is less than 50 at 1 year, you have a 90% chance at 6 years of being free of any of the poor outcomes or events that are listed on the left. However, if your GGT is greater than 50 at 1 year, you have only a 65% chance at 6 years of being free from one of the poor outcome events. So this was one of the first studies to show that GGT is a sensitive biomarker that can predict outcome. Now, I will say we don't really understand why those children who normalize their GGT to less than 50, we don't really understand how that happens. Next slide. This same group has recently published their work on another tool that, again, I think is going to be very powerful at predicting progression. This is known as the Sclerosing Cholangitis Outcomes in Pediatrics Index, or SCOPE. The scoring system is based on the patient's total bilirubin, albumin, platelet count, GGT, and if they have large bile duct disease. On the right is showing you the degree of abnormalities of each of those parameters, and it reflects the score that is given. Now, if your total SCOPE score is 0 to 3, that would predict low risk for progression, 4 to 5 is medium risk, and 6 to 11 is high risk for progression. Next slide. So shown here is how we are going to be able to use this SCOPE score to guide our patients and families on progression of disease. I've highlighted an example with the green boxes. So if your SCOPE index score is 5, we could predict that you would have a 10% probability of needing a transplant in the next 5 years and a 25% probability of having a hepatobiliary complication such as a dominant stricture or portal hypertension in the next 5 years. So this is hot off the press. It has not gone into clinical practice yet, but I really think it's going to help guide our families. Next slide. As I mentioned earlier, I also think that FibroScan will be a powerful tool to monitor progression. Now, this is an adult study, and they did liver biopsies on all of these adults at the time of enrollment, and then they divided them based on the severity of their liver fibrosis at the time of enrollment. And if they had mild fibrosis, that's shown in green, moderate in blue, severe in yellow, and those with cirrhosis at the time of enrollment are in red. They then followed those patients for 9 years and did FibroScans every single year. If you started out with moderate, severe, or cirrhosis at the onset of monitoring with FibroScan, you had a more rapid progression of disease that was predicted or demonstrated by the FibroScan. However, if you had mild disease, which is what most of our children have, you had a much slower rate of progression, and that's shown by almost the flat green line on the bottom. So FibroScan, definitely a tool to use on an annual basis. Next slide. And finally, what are the current and potential future treatments for PSC? Probably the most well-known medicine is ursodeoxycholic acid, or ursodiol. And ursodiol has many mechanisms of action. It's water soluble and thins out the bile. It helps protect the liver cell from injury. It promotes bile acid movement from the liver cell into the bile ducts, and it has mild anti-inflammatory properties. Next slide. Many of you may recall a study that was done over a decade ago now in adults looking at high-dose ursodiol for the treatment of PSC. They had 150 patients, and these patients were either given placebo, meaning no drug, or high-dose ursodiol. They found that ursodiol improved the liver tests. However, ursodiol was also associated with a twofold increase in transplant. So in adults, the use of ursodiol is controversial. In children, the majority of children, we will at least trial with ursodiol. And a couple of reasons for this is, number one, we use much lower doses than that high dose study. We use approximately half of what was reported in adults. And our children have much lower frequency of severe disease and cirrhosis, and they may respond differently to ursodiol compared to adults. Next slide.
Dr. Mack, you have 5 minutes.
Thank you. So this is the results from another recent study, multi-centered study on the effect of ursodiol based on the GGT response. And in this study, children who were on full dose ursodiol were slowly weaned off to no ursodiol. And as you can see, this is a subset of the total. There was a significant increase in the GGT when the children were taken off ursodiol. And when they restarted the ursodiol, the GGT came down to normal. And so this told us that potentially ursodiol is associated with decreased biliary injury. However, it was a small pilot study, and we really need a much larger placebo-controlled trial to understand the benefit of ursodiol. Next slide. Now, throughout the decades, there have been many medications that have been tried in adults with PSC, and none of them have been shown to have definite efficacy at preventing progression of disease. On the left are a list of immune modulatory medications that have not been proven to be effective, and on the right, a list of antibiotics. And the one antibiotic that does show some potential is vancomycin. Next slide. So shown here are the results from one of the first publications on the use of vancomycin in children. And these are the lab test results of 14 children. Each child is a different colored line. In the upper left panel is your SED rate or inflammatory marker. The right is ALT and the bottom is GGT. And it's showing you the results of those lab tests before or after starting the vancomycin. As you can see, the majority of children had improvement in these liver tests. And there's been at least 2 other studies that confirm these findings of improvement in liver tests. Next slide. So why shouldn't every child with PSC use vancomycin? The biggest reason is the lack of an appropriate placebo control in all of the previous studies with vancomycin. You can't definitively know if a drug is the reason for the impact, in this case, a decrease in GGT, without comparing it to a group of patients who do not receive that drug. And to date, there has been no large, properly controlled placebo study on vancomycin, and that needs to be done. There's also no data on long-term outcomes on the use of vancomycin. Specifically, does it decrease the incidence of transplant or other complications? And then there is a theoretical risk of side effects associated with long-term use of oral vancomycin. There is the potential that with oral vancomycin, you could create highly resistant colonic bacteria that are resistant to vancomycin. And if you have intestinal inflammation and you're chronically taking vancomycin, that can get absorbed then into the bloodstream in the setting of inflammation of the intestines, and that then could alter your kidney function. Next slide. So to summarize, I think honestly the future looks bright for treatment trials for PSC. Shown here are those same factors that are associated with the pathogenesis, and the goal with treatment is to target those various factors. So for example, with the gut-liver axis, both vancomycin as well as fecal transplant are being trialed. For bile acid retention, nor-ursodiol has shown promising results, as well as some of the others listed there. For autoimmune responses, inhibiting those responses, there's multiple agents that are being tested right now. And for fibrosis activation, simtuzumab is an antifibrotic that is currently under trial. So I really think these and others coming up the pipeline, we're going to find excellent therapeutics to target PSC. Next slide. So I just want to finish with the work that's being done through the NIH-funded Childhood Liver Disease Research Network. This is a multi-centered network in both the United States and Canada. And for the past year and a half, we've been working on an observational clinical trial in children with PSC, and we hope to get it started later in 2020. There's many aims to this study. We want to look at the natural history of PSC in children. We're going to be doing quality of life assessments. We're going to analyze the accuracy of those imaging studies like FibroScan and MRCP+ in predicting outcomes in children. And we're going to create a biobank of biospecimens so that we can do future studies aimed at understanding the many different factors involved in the pathogenesis of this disease. And at a worldwide level, there are multiple investigations going on pertaining to key immune pathways and microbiota that are involved in the pathogenesis of PSC, and this will likely lead to new future therapeutics targeting these areas. Next slide. Thank you.
Thank you, Dr. Mack. That was great. I would like to move on to our next speaker, Dr. Shikha Sundaram. Dr. Sundaram is an associate professor of pediatrics in the Division of Gastroenterology and Hepatology at the University of Colorado. She serves as the medical director of our pediatric liver transplant program here. She's also known nationally for her expertise in non-alcoholic fatty liver disease and for holding many leadership roles in various committees within the American Association for the Study of Liver Diseases, the American Liver Foundation, and the Studies in Pediatric Liver Transplantation groups. She will be talking tonight about liver transplantation for PSC. Dr. Sundaram?
Thank you very much, Dr. Brigham, and thank you to PSC Partners for the invitation. I really appreciate it. I'm going to be talking about liver transplant in pediatric PSC. Next slide, please. And next slide again, please. So we're going to hit on several points. I want to make sure that you understand the indications for liver transplant, what the prevalence of liver transplant is in pediatric PSC, risk factors for progression towards liver transplant, and if your child has a transplant, how do they do? And I want to give you some information on both the evaluation process and how you might, as a family, choose a transplant program. Next slide, please. I don't think that this group really needs an introduction to primary sclerosing cholangitis, but given that the prevalence is 0.2 cases per 100,000 children, liver transplant is really the only available life-extending treatment that exists. And as you can see on the right, there are approximately 600 pediatric liver transplants performed annually, and PSC accounts for about 3% of all of these transplants. Next slide, please. Indications for liver transplant in primary sclerosing cholangitis include a variety of complications of end-stage liver disease. Portal hypertension can be manifested as esophageal or GI varices or abnormal blood vessels that may bleed, hypersplenism in which the spleen grows and traps red blood cells, white blood cells, and platelets, all of which can result in significant bleeding, ascites or fluid buildup in the belly, severe fatigue, itching, encephalopathy, which I describe as fuzzy or abnormal thinking, recurrent infection or cholangitis, and malignancy or cholangiocarcinoma. Next slide, please. Cholangiocarcinoma in pediatric PSC is very, very rare. And by rare, I mean that there are less than 15 reported cases in the medical literature, all of whom were older adolescents, 15 to 18 years of age, with a median diagnosis of 6 years after the PSC was diagnosed. And we currently don't understand what the optimal surveillance in children is. So we specifically bring it up because it's something that adult hepatologists and adult PSC patients think a lot about. Next slide, please. So how common is it for a child with pediatric PSC to need a liver transplant? What I'm showing you here is actually transplant-free survival after the diagnosis of PSC. And I'll draw your attention to two specific points. Along the bottom, you can see years since diagnosis. So if you follow the blue line, at 5 years after the diagnosis of PSC, about 85% of patients are transplant-free, living with their native liver. And if you take this out to 10 years after transplant, still about 10 years after PSC diagnosis, still about 70% of children with PSC are living with their native liver. Next slide, please. So what might predict which patients are going to need a transplant or not need a transplant? One of the things that we think a lot about is inflammatory bowel disease, and does this increase or decrease the possibility of liver transplant? We believe that IBD is present in up to 80% of PSC patients, primarily ulcerative colitis, but also some with Crohn's disease. It may be diagnosed before or after the diagnosis of PSC, and it may be asymptomatic or symptomatic. And as a result of that, it's our standard practice to look for IBD in patients with PSC and vice versa. There are two sets of data that help us understand the impact on transplant. The group from Boston Children's looked at their center's experience and noticed that 22% of patients with PSC and IBD needed liver transplant, as compared to 41% of PSC patients without IBD. And then the PSC consortium, which Dr. Mack was speaking to earlier, also looked at this data and suggested that PSC patients with IBD were less likely to develop end-stage liver disease requiring liver transplant as compared to PSC patients without IBD. Next slide, please. What about portal hypertension? And again, this goes back to data that Dr. Deneau and his colleagues have published from the PSC consortium. And so portal hypertension I've described, and on the left side, you'll see portal hypertension diagnosis after PSC. So I chose 5 years as an example down at the bottom. And if you look across, you can see that 21% of patients with PSC develop portal hypertension at 5 years after their diagnosis. If you happen to have the diagnosis of portal hypertension with PSC, and this is on the right side, again, liver transplant-free survival. At 3 years after the diagnosis of portal hypertension, about 50% of patients are transplant-free. Next slide. Similarly, when we look at biliary complications from the same data set, you can see on the left that at 5 years after the diagnosis of PSC, 12% of patients have a biliary complication. And of those who have a biliary complication, if you look at 3 years after that diagnosis, still 50% are transplant-free. Next slide, please. What about the outcomes of liver transplant, specifically for pediatric PSC? And when on this slide, I'm showing you national data from UNOS looking at patient survival. And along the bottom, you can see that 1 year survival after transplant is 97% and 5 year survival is 93%. So if your child needs a liver transplant, their outcome is excellent. Next slide, please. As transplant doctors, what do we think about with pediatric PSC that's a little bit different than other patients who've had a liver transplant? One thing is the possibility of disease recurrence. It's important to differentiate complications that may arise in any transplant patient versus disease recurrence. And honestly, it can be a little bit tricky to sort out. We never diagnose recurrence in the first 6 months post-transplant because there are just too many moving parts. Similar to PSC prior to transplant, patients will have a biochemical profile that's cholestatic, a high bilirubin, a high GGT, and increased liver test. They will show irregularity of their bile ducts, and it's important that the transplant team is able to say that the problem in the transplant is not related to an anastomotic biliary stricture, meaning where the donor and the recipient bile duct come together, a vascular problem such as hepatic artery thrombosis, which may lead to stricture from poor blood flow, a specific type of rejection called ductopenic or chronic rejection that impacts the bile ducts, or disease related to transplantation of an incompatible ABO graft. Next slide, please. We like to try to predict things and understand risk factors. And risk factors for recurrent pediatric PSC include younger age at transplant and a shorter duration of time between diagnosis and liver transplant. And this may have something to do with the severity of the inherent disease in those patients. Overlap syndrome, which Dr. Mack mentioned, with autoimmune hepatitis and PSC. The use of what we call extended criteria donors, which are typically not used in pediatrics. There is some question about the use of first-degree live donor liver transplants, and I'll talk a little bit more about this, but it is unknown the impact in children and inconclusive in adults. Specific immunosuppression using an induction called thymoglobulin, and recurrent acute cellular rejection. The presence of IBD, the data is very inconclusive, and in pediatrics, we really don't have a lot of data on this, so we just don't know. Next slide, please. So I'm going to switch gears because I want to share with you a little bit about what happens during a liver transplant evaluation. What happens if somebody says that your child may need a transplant? The first part of the transplant evaluation is to establish that the patient actually meets indications for transplant, which includes confirming the diagnosis and understanding any systemic manifestations of disease along with a current management plan. That may allow us to identify opportunities to maximize medical therapy and determine if there may be other surgical options outside of transplant to put into play. It may give us the opportunity to assess feasibility of live donor, to anticipate any complications that may happen through the transplant process and hatch solutions before they occur, to establish a real relationship between the transplant team, the patient, and the family, ensure that the patient and the family really has a commitment to the long-term care required for transplant, and to confirm that finances, i.e. insurance, are available to take care of the cost of transplant. Next slide, please. The evaluation process is actually multi-step, and I've highlighted it here. The first thing that happens is that a patient is referred in for an evaluation. And on the back end, that means that our team is gathering records and imaging studies and laboratory tests, while at the same time asking insurance companies for permission to perform the evaluation. We then perform the formal evaluation. I'll explain that in a second. A patient is then presented to the center's transplant selection committee for a decision, and the patient is either approved and therefore listed, or not approved and then other alternative strategies are explored. Next slide, please. So the transplant evaluation takes about a day and a half, sometimes 2 days, and it's pretty intense. You meet with medical and surgical teams that include not just the surgeon and the hepatologist, but also the nurses and the anesthesiologist and infectious disease experts. Our families and patients spend a good amount of time with the psychosocial team, including our social workers and psychologists, as well as with nutritionists, financial counselors, and transplant pharmacists, along with any specialty care that may be important. And then they undergo a lot of testing that includes blood work, radiology tests, echocardiograms, and dental exams. Next slide, please. What are the goals of the transplant team, my transplant team and other transplant teams? Our goal is to restore optimal health for your child and therefore optimal health and well-being for your family, and to support the patient and your family through the transplant journey. I say to almost every single patient that I meet, probably several times, that when we do your transplant, you become a part of our family and we become a part of your family, and that we're going to be here every single step of the way because it's a big to-do. Next slide, please. So how do you choose a liver transplant program? And I think the reality is that as parents and as patients, you have some choices. So I'm going to highlight some things. You want to understand the experience of the transplant team. You want to understand what your surgical options are going to be. Does the program offer a living donor? Is it directed or is it non-directed? Do they offer split grafts? What are the results of the transplant program? What's the survival on the wait list? What are their wait times? What are patient and graft survival? Are they friendly to you, to your child, and to the doctor who sent you in? And insurance companies, fortunately or unfortunately, sometimes do dictate some of the options that we have at hand. Next slide, please. So the first thing that's really important is to choose a pediatric liver transplant program if you can, assuming that your child is a child. And the reason that I say that is that there are only about 600 pediatric transplants performed, as I mentioned earlier, per year. There are upwards of 125 to 150 transplant programs across the country, shown in purple. The vast majority of these, shown in green, are adult transplant programs. And shown in pink at the bottom of that chart are those that say they do some pediatric transplant but are functionally adult programs. The ones that are probably most important for this group are those that are pediatric programs only in brown or mixed, meaning they really do both adult and pediatric patients, shown in turquoise. And again, the reason that that's important is because children are not just small adults, not in their physiology, not in their size, not in their needs. And pediatric liver transplant programs are going to be completely focused on the care of the whole child. Next slide, please. Let's talk a little bit more about the transplant team experience. So this is really interesting data that came out of the Baylor Surgical Group. And they looked at programs, transplant programs, that performed less than 5 transplants per year or more than that. And what you'll see on the left-hand side is the percent transplanted. And what you'll see are 2 big groups of lines. Those centers that performed less than 5 transplants per year as compared to all others were significantly less likely, 50% less likely, to actually perform a transplant in those patients who were listed. And if you look on the right-hand side of the screen, those centers that we would consider small centers performing less than 5 transplants per year, if your child went to transplant, their survival was significantly less than that of transplant programs that were performing more. So what does that mean? It means that the transplant team's experience is really important. Sometimes transplant is smooth and sometimes it's easy, and it's wonderful when that happens, but sometimes it's not. And when it's not easy or it's not straightforward, it's really important that everybody who's touching your child and a part of the transplant experience really has a lot of expertise. The surgeon, the hepatologist, the anesthesiologist, the intensive care doctor, the infectious disease specialist, so that if something isn't going perfectly according to plan, there are layers of people who've seen it all and done it all and know how to get your child back to optimal health. Next slide, please.
Dr. Sundaram, you have 5 minutes.
Okay, graft options. So all transplant programs do whole organ. It's important to understand if they offer split transplant, meaning one organ, one deceased organ, goes partially to an adult, partially to a child. Do they do cut down transplants, meaning the ability to surgically modify a large organ to fit a child? And do they do live donor, where a portion of an adult's liver is given to a child? Next slide, please. As you can see on the left-hand side, living donor in green is a small fragment of what is done in terms of pediatric liver transplant. Most patients who receive a living donor transplant receive that organ from a related person, either in purple or more distantly related in tan. There are some children, and this is on the increase as shown in red, who receive a directed donor from someone who is unrelated to them, a friend, a godparent, a neighbor, etc. And what you can see in green on the bottom is that there is an increase in, quote, other living donor transplants that we call non-directed donors. These are really good Samaritans who come into a program and say, I'd like to give a part of my organ to a complete stranger. And while I think it is an incredibly remarkable gift, and we are very lucky and our patients are very lucky to benefit from this, it's a huge sacrifice. And these are people who have gone above and beyond, certainly. Next slide. So why consider living donor liver transplant? Well, first of all, it may give your child faster access to liver transplant, which means they're going to be less sick going into transplant. And it allows you a little bit of control to actually schedule the transplant, which means you can help fly your people in if you need be, right? To have support systems around you. Find people to help take care of other family members and children. Let your job or workplace know that you're going to be out for a little while. So there's some real benefits. Live donors are independently evaluated by a live donor team at adult hospitals. We use the University of Colorado. And as I mentioned, they may be directed donors or non-directed donors. Living donor candidates are really the picture of health. 18 to 15-year-olds with essentially no medical problems and appropriately normal anatomy. And what you can see on the right side is that more than half of our transplants over the last 2.5 years have been living donors, shown in the light blue. And in fact, 2/3 of these have been the non-directed, or what we sometimes call altruistic donors. Next slide, please. So I'm going to buzz through this a little bit. If your child is approved for transplant, they go on the UNOS waitlist. And typically they are listed based on a calculated MELD-PELD score, which I'll show you in a minute, but as a math formula. On occasion, patients are given an exception score, which means that the transplant team feels that their calculated mathematical score does not adequately reflect their disease severity, and therefore they need more points. And you can see some examples of why we might ask for that. Next slide, please. So the MELD score, a model for end-stage liver disease, was developed as a predictor of 3-month mortality. It is used for children ages 12 and up. You can see the formula here. It takes into account bilirubin, INR, and creatinine, and there are multiple programs online that do this math for you. Next slide, please. For children who are less than 12 years of age, we use the PELD, or Pediatric End-Stage Liver Disease Score, which you can see here again, the formula. It takes into account bilirubin, INR, albumin, age if they're less than 1, and if they have growth failure. Next slide, please. So the next thing that I want to talk about is SRTR data. And this speaks to, again, how do you choose a transplant program? So on the bottom of the slide, you'll see the web address for the SRTR. You can also just Google SRTR data and find it. Every transplant program has SRTR data that is publicly available, and it's important to understand it for your transplant center or transplant centers that you're considering. You can search by program, you can search by state, you can search by region, adult, pediatric, lots of different things that you can do with it. And it gives you a chart, worse or better, more or less bars. And it will give you 3 factors: survival on the wait list, getting a deceased donor transplant faster, i.e. wait list time, and 1-year survival. I think the easiest way to understand this is to walk through an example. Can I have the next slide, please? So these are 3 centers that obviously don't exist, hospitals A, B, and C, and this is essentially what you would see. If you put in where you were located, it would tell you distance to that individual hospital. It will tell you how many deceased donor transplants are done in a year down a column, and how many living donor transplants are done in a column. And that will help you answer some of the questions that I posed earlier. The next column is survival on the wait list. So if you look at the number of bars, you can see pretty clearly that Hospital B has only 2 bars, so their survival on the wait list is less than Hospital C's that has better survival on the wait list. When you look at the next column, getting a deceased donor transplant faster, some of us think of this as wait list time. Each of these hospitals has similar number of bars or similar wait list time. And then as you look at the third column, 1-year liver transplant survival, you will see that Hospital C has 3 bars as compared to hospitals A and B. So their 1-year survival is not quite as good. Now, obviously, this is only a part of the picture, and it's important to ask those other questions. One of the reasons that I think it's important to understand this information is because every family has the opportunity to do what we call multi-list, meaning that you can list, if your insurance company will allow you to, in more than one hospital. Usually not hospitals very close together, but to allow your child access to potentially increased number of deceased donor organs. And so as you think about this process, this type of data can be very, very helpful. Next slide, please. So thank you very much, and I'll be happy to take questions at the end.
Thank you so much, Dr. Sundaram. That was great. Our third and final speaker here is Dr. Juri Boguniewicz. Dr. Boguniewicz is an assistant professor of pediatrics in the Division of Infectious Diseases at the University of Colorado. He serves as our liver transplant infectious disease expert within our multidisciplinary group. And he's the current chair of the Children's Hospital Colorado COVID-19 Antiviral Treatment Committee. And he will be discussing a very timely and important topic today that should hopefully answer a lot of questions that you may have, entitled Keeping Kids with Liver Disease Safe During COVID-19 Epidemic. Dr. Boguniewicz.
Thank you, Dr. Brigham, for that introduction. And I'd like to thank Dr. Mack and PSC Partners for inviting me to speak to you today about COVID-19 and its impact on children with liver disease. Next slide, please. So I don't have any financial disclosures, but I do have some disclaimers before we start. So first, it's important to keep in mind that the data and information on COVID has been rapidly evolving, and we're learning more every day. It's really been much like drinking from a fire hose. So next, please. One more. There's a central database that keeps track of all new publications dealing with COVID-19, and you can see that since late April, there's been about 2,000 new articles coming out every single week. So it's a lot of information to keep track of. Next. One more. However, there remain a lot of questions still about COVID-19, particularly as it relates to children and special populations like those with liver disease, and high quality data on children is still fairly limited. So keep this in mind that what I'm going to discuss is really based on what's available right now. And as we learn more, some of these recommendations may change. Next slide, please. So my goals are to give you a quick overview of what we know about children and how the pandemic's affected kids, as well as discuss implications of COVID on children with liver disease and transplant. And then I want to focus the rest of the talk on recommendations for preventing children from getting COVID and what to consider when making the decision about returning to school, as I'm sure some of this is on the forefront of many parents' minds right now. Next slide. So far in this pandemic, children have accounted for just a small fraction of COVID cases. About 7% of lab confirmed cases in the US have been in children. However, because these figures are based only on children who have had testing sent, it likely underestimates how many children have actually had COVID. This figure from the Center for Disease Control shows hospital stays for COVID-19 over time by week and is broken down by age. And you can see that children under 18 in the gold and silver slivers at the top of each bar account for only about 2% of hospitalizations for COVID. The incidence, however, of hospitalizations over time has been steadily increasing in children, though they still remain much less likely to be hospitalized than adults. Next. Fortunately, compared to adults, the majority of children usually have a mild illness with COVID. In this systematic review of over 7,000 confirmed pediatric cases, about 60% or so had either a mild or asymptomatic infection. Another 40% had a moderate infection that was defined as either pneumonia by exam or chest x-ray, but were not requiring oxygen support. And only 2% of children were severe, meaning that they did require oxygen support, and less than 1% were critically ill. Fortunately, less than 0.1% of children died due to their COVID illness. And so while the majority of children with COVID have a mild or asymptomatic infection, and the vast majority will not require hospitalization, we do need to keep in mind that it can cause severe disease in children of any age, and we need to respect that. Next slide. So this diagram is meant to illustrate the different phases of COVID-19 infection, and I want to point out how patients who are immunocompromised or immunosuppressed may differ from the general population. So first, the early stage of infection, or the viral response phase on the left-hand side of this diagram, typically lasts about 1 to 2 weeks in most otherwise healthy patients. This is the stage when the virus is considered most active and patients are thought to be infectious. In immunocompromised patients, this phase may be extended, and there's concern that immunocompromised patients are capable of transmitting the virus longer, sometimes up to 21 days or more. Second, in a small subset of patients, even after the virus is cleared, they can develop an overly active immune response that can cause problems such as shock or heart or respiratory failure. So in children, there's a unique entity that you may have heard of, multisystem inflammatory syndrome, or MIS-C, that can occur in this late stage and causes inflammation in multiple organ systems, most concerning in the heart. And children with this often require ICU level care, but this still remains a rare phenomenon, and the majority of children who have had it have usually been previously healthy. There's actually some thought that immunocompromised patients may be less likely to experience these late complications of COVID, as their immune response may be suppressed. Next. Adults with certain medical conditions are at greater risk for severe disease and bad outcomes with COVID. However, the data on children is really much more limited. In this large CDC study that included information on about 15,000 children with underlying conditions, hospitalizations, you can see, were about 5 to 7 times higher for patients with underlying medical conditions than for children without underlying conditions. Fortunately, few patients were critically ill or died as a result of their infection, though again, serious outcomes were a bit more common in those with underlying conditions. Next. However, only 24 patients with a history of liver disease were included in this study, and these numbers are really too small to draw any meaningful conclusions about the risks associated with any one medical condition. There was a large database study that found that pre-existing liver disease was associated with increased risk of hospitalization and death due to COVID if patients had evidence of cirrhosis or fibrosis. However, this study included very few children, and only 4% of patients, or 10 total, had a diagnosis of PSC. Notably, the American Association for the Study of Liver Diseases specifically mentions that there is no evidence that patients with cholestatic syndrome, such as PSC, have increased risk of acquiring COVID. In some adult studies, patients with transplants were at increased risk of death due to COVID, and the CDC has considered this group to be at higher risk. However, it should be noted that in these early studies, the majority of transplant patients who had bad outcomes frequently had other high-risk medical conditions such as heart disease or diabetes, and were being treated during surges of the virus when resources may have been more limited. Next. So though the data about the impact of COVID on children with liver disease is limited, there is an ongoing nationwide study from NASPGHAN and the Society for Pediatric Liver Transplantation that's enrolled about 45 patients so far with underlying liver disease or who are post-transplant with confirmed COVID infection. Next. This data is updated weekly, and you can see the breakdown of underlying conditions for patients with native chronic liver disease on the left here, and those who have had a liver transplant on the right, with biliary atresia being the most common underlying condition in both groups. Notably, no cases of PSC have been reported among the patients included in the other category. Next. About 75% of patients with chronic liver disease in the study have been admitted to the hospital, and about a quarter required ICU level care, whereas about 70% of those with liver transplant have actually been able to be managed on an outpatient basis. So far, about a third of chronic liver disease patients have required some oxygen support, and one transplant patient required oxygen support via a nasal cannula. All these patients have recovered from their illness except for one patient that passed away from non-liver related causes, and two still remain hospitalized. These are small numbers, but it suggests that so far the experience in children is different than in adults, and that even in those who are sick enough to be hospitalized, that they usually don't require supplemental oxygen, and they've usually recovered. Next, please. So, while this early day is encouraging, this is a registry study that relies on voluntary reporting of participating institutions, and it can give us a sense of how kids with liver disease and liver transplants have done so far with COVID, but it really can't address the question of, are children with liver disease at greater risk for contracting the virus or having severe outcomes compared to the general population. So most transplant centers are still exercising caution based on a combination of the adult data, concerns about the ability to fight infections while on immunosuppressing medications, and experience with other respiratory viruses, which can be associated with more severe disease in transplant patients. It's important to keep in mind that this data has really been occurring in a time of unprecedented public health measures, including school closures. So as things open back up and kids start returning back to school, it'll yet to be seen how this impacts the number of infections in kids. Next slide. Given the early concerns about unknown risks of this newly identified virus in a generally susceptible and fragile patient population, the number of living donor transplants here on the lower left-hand side, this is data from UNOS, shows that they did decline as the number of COVID cases began to rise since about early February. But since May, the number of overall pediatric liver transplants at the top here has been increasing and has since reached or exceeded pre-COVID levels. Next. So early on in the pandemic, the American Society of Transplantation released expert-driven recommendations to guide transplant centers in this time of uncertainty. These are generally meant to be conservative recommendations to protect transplant candidates and recipients from the potential risks of COVID, and include routinely testing recipients and donors for COVID just prior to transplant, avoiding transplant if a donor or candidate has an active infection, and potentially delaying transplant in the case of an exposure to a person with COVID, though this really needs to be weighed against the risks of delaying the transplant. Next. Other general recommendations for keeping all children safe include those with, including those with liver disease and transplant, include wearing a face mask in public places or when interacting with people who don't live with you, maintaining at least 3 feet and ideally 6 feet of distance between your child and others when out in public. It's important to remember that the major mode of transmission of this virus is still respiratory droplets, but high-touch surfaces like doorknobs or handles can contain the virus, and small children may be particularly at risk of picking it up from these surfaces if they're frequently touching their face after touching these surfaces and they're not washing their hands. So disinfection of high-touch surfaces and frequent hand washing is encouraged. At the same time that you're doing these measures, you really want to try to avoid unnecessary travel, particularly by plane, large gatherings or crowds, and of course, contact with people who are experiencing symptoms or have a known COVID infection, as these all increase your risk and your child's risk of contracting the virus. Next slide. So despite some early mixed messages, face masks do help prevent spread of the virus, and it's recommended that all children above the age of 2 wear them when in public or when around people who don't live with you. I like this figure taken from a CDC investigation of a hair salon in Missouri where an employee had COVID-19 and exposed over 100 clients, but because the employee and the customers were all required to wear face masks in the store, none of the clients contracted COVID as a result of this exposure. In contrast, some of the employee's family members and a coworker who are not masked around the sick individual did wind up developing COVID. Next. So it's both safe and important for children with liver disease and transplant to get updated on their vaccines at this time. We've seen a dramatic decline in the receipt of childhood vaccines during this pandemic, which is concerning because it means communities may be more susceptible to other illnesses like measles or pertussis that can quickly spread and cause severe illness, particularly in kids with weak immune systems. So for kids with solid organ transplants, it's especially important that they stay up to date on their vaccines, as we know from a study done by one of our transplant hepatologists, Amy Feldman and colleagues, that nearly 16% of patients with a transplant were hospitalized for a vaccine preventable illness within 5 years of receiving their transplant, which is about 90 times higher than in the general population. So making sure vaccines are up to date prior to transplant preferably, or catching up on vaccines after transplants, critical to preventing these types of infections. Next. So now I want to discuss considerations for returning to school, and I want to preface that just like with the decision to transplant, with returning to school, the risk of infection needs to be weighed against the benefits of attending in-person schooling. I've hopefully laid out earlier what we currently know about the risks and consequences of COVID in children with liver disease and transplant, which albeit is still limited. While we don't know for certain what the risk of transmission of the virus between children will look like when schools reopen, we do know that in-person learning is important for children, and experience from other countries that have successfully reopened schools without having a resurgence of the virus suggests that there's things schools can do to limit the spread of virus and keep kids safe. Next. So in addition to considering your child's individual risks, there are other things that need to be considered in making this decision about returning to school. And it really needs to be an individualized one that considers your child and your family's unique circumstances. And I'm going to discuss each of these in a little bit more detail. Next, please. So it's important to mention the benefits of in-person learning, and the American Academy of Pediatrics has come out strongly to say that in-person learning is critical for the development of children and adolescents and is preferred when it can be done safely. In addition to the educational benefits compared to remote learning, in-person schooling is important for children to make social and emotional connections and to access other important services that schools provide, like mental health counseling or special education. In addition, many children rely on school for nutritional support and free lunches, and in-person schooling promotes social and racial equity, as families that don't have access to technology or the resources or supervision to provide in-home learning are at a disadvantage when it comes to remote learning. So you want to think about what alternatives to in-person learning are even available to your child, and if those are really feasible for your family, and if they'll provide similar benefits to in-person learning. Next, please. So it's important to consider the rates of COVID in your community when thinking about returning to school. When there are larger numbers of people who have coronavirus in the community, the risk of being exposed to someone with COVID increases with any social interaction, including at school. So local and state health departments will usually have the most updated and accurate data on the rate of community spread and can provide helpful figures such as this one that show the percentage of positive tests in a state or area. Some consider it a high community spread when there's more than 10% of tests that are positive, or more than 10 per 100,000 people are positive. However, school districts should really be following the advice of public health authorities about when it may be safe to open schools and when they should maybe consider closing, at least temporarily, if there's an outbreak or resurgence of the virus. Another good resource for this is the Harvard International Global Health Initiative that has a website that breaks this down by county data, and we can provide that link on the PSC website. Next slide.
5 minutes.
Thank you. So if your family members, if you have family members living with you who are older or have an underlying medical condition, it's important also to think about their risk and what it means if your child brings home COVID and potentially transmits it to that family member. So far, it seems that younger kids are less likely to transmit the virus, but older children and teenagers may be just as likely to spread the virus to adults. So the CDC's issued guidance based on the available evidence about which conditions may put someone at higher risk for contracting COVID and getting severe disease. So again, this mostly applies to adult data, but you can see that liver disease in and of itself is considered to have limited evidence, but may increase the risk for severe COVID disease. And this list can be found at the CDC's website under people with certain medical conditions. Next, please. So while our data in children with transplants is growing, our experience with other respiratory viruses in children who have had a transplant suggests that certain patients may be at higher risk if they acquire COVID. This is a figure that summarizes recommendations from a group of transplant infectious disease experts that's been endorsed by the American Society of Transplantation and Split. And in general, they would consider children who are early out from their transplant within the first 6 months, or on increasing or high levels of immunosuppressing medicines, or have had an episode of rejection recently, or have multiple medical conditions that may put them at higher risk, such as obesity or chronic lung disease, to be at higher risk for bad outcomes with COVID. In addition, those children who are behaviorally or developmentally can't follow precautions, such as wearing a mask or doing hand hygiene, they'll be at higher risk. And if they attend a school which can't ensure that kids are adhering to these precautions, then that may also put those children at higher risk. So there's multiple things to consider when discussing risk with your physician. So children at lower risk in this green box, they usually have either stable or low amounts of immune suppression. Often they're just on one drug or maybe not on any immunosuppressing drugs. They've not had any recent episodes of rejection, and they typically shouldn't have other high-risk conditions that could predispose them to worse disease with COVID. And importantly, they can follow the precautions that we've been recommending. So this group also has provided a nice FAQ for parents of transplant patients, but I think the principles can be applied to any child. These can be found through a link at the AST website and will also be posted on the PSC Parent COVID website. Next slide. The American Academy of Pediatrics has laid out recommendations for high and low priority measures schools should be taking to prevent COVID. This varies slightly by age group and type of school, but many of the same principles apply across schools. I won't go through each of these, but parents should make sure that their schools are taking these measures, that they have a plan in place if students or staff test positive, and that they're communicating this plan and updates to parents frequently and readily. So you should ask your school what precautions they're taking so you know what's being done to keep your kid healthy. And it's important to disclose your child's medical condition to school officials so that they can work with you to develop an individualized plan and make accommodations if needed to promote your child's learning and ensure their well-being. So if schools are able to enact these measures, this may actually be the safest school environment immunosuppressed children have seen in some time, and these precautions should also be helpful at reducing common infections such as flu, which we know spread easily amongst children in school and can have severe consequences in medically fragile children. Next slide. So it's not possible for me or any other physician to give you a clear answer and give you 100% assurance that your child is safe to go to school or shouldn't go to school. It really needs to be an individualized decision. And we know this is a difficult one for families, especially for those with kids with chronic medical conditions. So the CDC's published a decision-making tool for parents to help them with this decision. And it's really meant to serve as a checklist for self-reflection about your level of comfort with the different areas I've discussed, and what questions you still have that you can address with your physician or school in order to be able to make this decision comfortably. Next, please. So to summarize, children can certainly get COVID, but most will have a mild illness course and won't require hospitalization. However, children with certain medical conditions may be at higher risk for severe COVID disease, though it still seems rare. We have a lot of unanswered questions about children with liver disease and transplants, but there's research currently being done and evidence is accumulating. And in-person learning is preferable, but the decision to return really needs to be an individualized one that takes into consideration your child and your family's individual circumstances. Next. So there's a lot of questions that still remain to be answered, and it'll likely impact recommendations for children as it pertains to COVID. For instance, what really are the risk factors for acquiring COVID and developing severe disease? How commonly do children spread the disease between each other in different settings, including within school? And do you develop immunity after infection? And if so, for how long does it last, and what does it protect you against? There's several vaccine candidates that are being researched, which is hopeful. If any are improved, we'll have to see, who will benefit the most from these vaccines and which person should get them. Next slide. This is a list of resources that I mentioned in my talk, most of them pertaining to returning to school, but there's also a more detailed presentation of the recent data from the Hepatology COVID registry that I discussed that's available from AASLD on YouTube. And these resources are going to be posted later to the PSC COVID parent site. Next. So thank you for your attention. I'll turn it back to Dr. Brigham, and I'm happy to answer any questions during the Q&A portion.
Great. Thank you so much. Thank you to all three of our speakers. Those were great talks. And now we'll transition to the Q&A segment. We will go a few minutes over 7, so bear with us. We'll try to answer as many questions as we can. The first question is for Dr. Mack. So obviously PSC is a chronic illness. How do you explain to your patients what that means? And how do you manage the stress that a chronic illness brings? And how do you explain it versus the patient's friends who have limited colds and other diseases? And what kind of support are there for those patients?
I think that when we're trying to counsel our patients who have chronic diseases, the first thing we let them know is that we're going to be there for them. We're going to walk them through every step. If they develop symptoms, we're going to walk them through new research studies that become available. So you really want to partner with the patient and the family and let them know that you're going to be there for them as they grow in childhood with their disease. But we do let them know that it is something that currently we don't have a cure for. We can't reverse the damage that's been done in that liver and the biliary tree. And the most important thing is to lead a really healthy lifestyle and stay in contact with your doctor if you are going to be developing symptoms. So I'm not sure if that was enough for the question, and maybe Shikha would want to chime in. But we do try to provide hope because there is hope. There's so much research going on for new drugs to stop the progression that I really like to keep it optimistic because that is what the future holds.
Perfect. Thank you so much. Dr. Sundaram, if patients don't live close to a transplant center, either that offers living donation or that's a good transplant center, do you recommend that they move somewhere where they would have access to that, or can they be multi-listed?
That's a great question. Thank you, Dr. Brigham. No, we don't recommend that people move necessarily to be close to a transplant center that meets an individual patient's needs. I can't speak to what every single transplant center does, but my experience with a few has been that after transplant, usually patients need to be nearby, within an hour or so for about 4 weeks. And there are various accommodations that hospitals can help families make. And then visits often space out quickly from then, every 2 to 4 weeks to every 3 months to 6 months, so that a year after transplant, we're often only seeing a patient once a year. It's very, very common at Children's Colorado that we have families that are coming from 10 and 12 hours away. And logistically, we know often 24 hours ahead of time if there's a possibility for a deceased donor transplant. And so we think ahead about how to get families here in plenty of time. And certainly for a living donor transplant, we don't have a time crunch. We can easily plan everything. So no, you certainly don't have to move. Denver's a beautiful place to live.
Agreed. Dr. Boguniewicz, you mentioned that it's important to get routine vaccination, but for those who have PSC without a transplant, do you think it's better or worse to wait on routine vaccination?
I definitely would not be waiting on routine vaccinations and would be recommending getting caught up on them for the points we mentioned. Once you have a transplant, your ability to respond to vaccines is much lower than if you're not immunosuppressed. So really, this is the best time to get vaccines. And it's important to get caught up. And the reason we have vaccine schedules and the reason we have age recommendations for different vaccines is because that's really when we worry about these vaccine preventable illnesses affecting kids and when kids are going to be at highest risk. So for school-age kids, and someone going back to school where they may be exposed to other kids, and we know that vaccine uptake has been decreasing in certain communities and during this pandemic, really the best way to protect yourself and your child against those infections is to get vaccines updated.
Perfect. Dr. Mack, what are the MRCPs and FibroScan that you mentioned? Are those available to all pediatric patients?
Certainly the MRCP should be available to all pediatric patients. And if your institution doesn't have one, then you want to seek out a neighboring institution because it's essential to do an MRCP on every patient in order to diagnose the disease. And down the road, sometimes we repeat it to help us see if the disease is progressing. FibroScan is a new modality. We've had it at Children's for 2 years now, and the adults have had it for a little bit longer. We're finding it's a very powerful tool to guide our patients about progression of their fibrosis, but not every institution is going to have that. And if you want a FibroScan, again, I would reach out to neighboring institutions that may have it. Also, there's some imaging studies I've been told recently, some imaging facilities that are offering it. And so you really want to reach out if you really want the FibroScan.
Perfect. Dr. Sundaram, does the Transplant Center help you find a living donor if you're interested?
That's a great question, Dr. Brigham. And the answer is yes, in a couple of different ways. Most transplant centers have an intake process by which anyone that an individual family knows who may be interested in live donor goes in and fills out essentially an online questionnaire that has some general information and health history to assess whether they might be healthy enough to bring in for a formal evaluation. So that's one option. And we talk through that with families, though we don't do the evaluation ourselves. And then the second thing is if we're thinking about non-directed donors or altruistic donors, if you will, those are people that come forward in partnership, typically with adult institutions or universities, and those are offers that are then made into the program. So yes, on both accounts.
Perfect. Dr. Mack, why is it that so many PSC patients have IBD, and how do you distinguish the abdominal pain that could be PSC pain or IBD pain?
Mm-hmm. So as Dr. Sundaram mentioned, that up to 80% of patients with PSC will also have the IBD. And we think, as I mentioned in the factors involved in the pathogenesis of this disease, that the colonic and intestinal inflammation associated with inflammatory bowel disease is trafficking certain parts of that inflammation is entering the liver through the bloodstream and altering your immune response and targeting the liver. So we really think that the reason you eventually develop PSC is most likely related to the inflammatory bowel disease and the inflammation that's going on there. And I'm sorry, what was part 2 of that question?
How can you differentiate the pain?
Oh, the pain. So it's sometimes very difficult to differentiate the pain from inflammatory bowel disease from that of PSC. However, the pain we worry most about with PSC is when it's associated with cholangitis. And that constellation of symptoms is fairly classic. You get right-sided upper abdominal pain under the rib cage pain associated with cholangitis, bacterial cholangitis from PSC, and that's usually associated with fever and jaundice of the skin or yellowness of the eyes. So when we see that constellation of symptoms and it's the right upper quadrant of the abdomen, we're more concerned that that could be a secondary bacterial cholangitis related to the PSC.
Perfect. This question can go both to Dr. Sundaram and Dr. Mack. So you presented a lot of distinction between pediatric and adult PSC. And how do we know the distinction? Is it when you're diagnosed? So if you're diagnosed prior to being 18, you have pediatric PSC for the rest of your life? Or is PSC different when you have an onset in adulthood?
That is a great question. I'll keep it brief and let Shikha chime in. There is controversy as to, is pediatric PSC simply an earlier event in adult PSC, and that it is the spectrum of the exact same disease. It just looks different when you're a child. It's more mild compared to when you're adult because it's just slowly progressing. And I'm in that camp. I believe that PSC is a single entity in children and adults. However, the manifestations of the disease are going to vary depending on the age that you are when you are diagnosed with it.
That's a tough question that the audience has posed. I'm in the same camp as Dr. Mack. I do think they're probably one and the same disease. Along a continuum. There is some data, some of which we showed, that suggests that the longer that you have the disease, regardless of the age in which it starts, the more likely you are to have complications and potentially being the key word, the more likely you are to have end-stage liver disease. And so I think when I'm specifically talking about pediatric PSC, I'm talking about the disease that starts in childhood and therefore has the potential to progress for a longer number of years or be present for a longer number of years.
But it's interesting because the adult patient that say they're diagnosed at 20 and they already have stage 2 to 3 fibrosis, when did that start? Did it start when they were 10 but they didn't have any symptoms? So it's a really tricky question.
You guys did a great job answering that. And then as far as Dr. Mack, a new diagnosis of PSC, this brings back the first question I asked. A lot of stress. Are there any resources that can be used or special accommodation for school? And who should they contact about that?
Yeah, so outlets for stress and trying to understand the disease and to find other kids like you that have the disease. Honestly, PSC Partners Seeking the Cure is one of the best platforms to find allies and friends going through the same thing. And I think Ricky could comment on that, because really what I've seen at the meetings that I've been to is the kids really form their own unit and bond and exchange their stories. So, and then the second part was of the question.
Yeah, for school accommodation, who can they contact about getting those?
Yeah, I mean, I will say approximately 40% of our kids don't really have many symptoms directly related to the PSC. However, if they do have significant itching, fatigue, we'll write letters to the school and let them know that the child may need to be dismissed more frequently, and that the itching is uncontrollable, things like that. So contacting your hepatologist is a good idea. Mm-hmm.
Dr. Boguniewicz, any advice on how to help children wear masks?
Yeah, so there's a link that should be posted. That was at the end of my talk, but healthychildren.org is a website that's put on by the American Academy of Pediatrics, and it's really geared towards parents and covering important health topics, including COVID-19, with children and with parents. And they offer tips on how to explain some of these difficult concepts, including how to get kids to wear masks. So, some of the things that they recommend is, mirroring. So, standing in front of the mirror, yourself and putting on a mask with the child. Putting a mask on their favorite stuffed animal or action figure can be helpful. Showing them pictures of peers or other children wearing masks can help normalize it. Talking to them about why the mask is important in an age-appropriate manner, and they sort of break down, how to go about that for different age groups. So I encourage you, if you're struggling with that, to check out healthychildren.org for the AP, and they provide a lot of other great tips about talking to kids about some of these difficult concepts.
Beautiful. Dr. Mack, Dr. Sundaram, any advice on transitioning pediatric PSC to adult hepatologists? It seems like a lot of times adult hepatologists are practice a little differently, and they might not want parents to be around for visits. So any advice about that?
Yeah, I'm going to let Dr. Sundaram answer that one because she headed our transition program.
I think a key to transitioning pediatric patients to adult care in general, and I use the word transition deliberately because transition of care and transfer of care are not the same thing. I think transition of care requires practice over time. And so it is about helping the adolescent practice getting comfortable with the medical team, comfortable with their diagnoses, comfortable with their medications, comfortable with making appointments or knowing what to do if they're feeling unwell. And so one of the things that families can really do is talk with their physicians and their liver providers about what should that look like for an individual patient. I personally, for PSC patients that are doing well, that I'm only seeing once or twice a year, I tend to give them a little bit of homework each time I see them. So I'll give them a little bit of a quiz. Can you help me understand what you know about your disease? Or can you tell me what medicine you're on? And I sort of have a list of things that I want them to work through, and then we add on to that the next time and the next time. I think the other thing that's really important in terms of practice, and there's plenty of data to show this to be the case, is that adolescents need to spend a little bit of time with their healthcare team by themselves without parents and guardians present. And that can be tricky because it's an intensive disease and kids can be nervous and adolescents can be nervous. And we as parents and providers can be nervous about that as well. But it's like anything else, it's about practice. So it doesn't have to be long. It can be 5 or 10 minutes, but that allows them to start to develop the one-on-one relationship with a particular provider that will then allow them to transition when they transfer their care over. Young adults, if you will, always have the opportunity to have a parent or a best friend or a sibling or someone else go with them to appointments. But you're absolutely right. Adult providers are really going to want them to speak for themselves, and perhaps for you as parents and guardians to fill in some of the gaps. So the best way to accomplish that is that sort of practice, practice, practice model. Dr. Mack, would you add something to that?
No, that was perfect.
All right, great. Well, that concludes the Q&A session. Thank you again for all of our speakers. Those were great talks. Hopefully you guys learned a lot from this, and I'll turn it around to Ricky now.
Okay, great. I'm sorry we kept you all over time, but that was absolutely terrific. It was fantastic. Really, I want to give a huge thank you to Drs. Mack, Sundaram, Boguniewicz, and Brigham for sharing updates on all aspects of pediatric PSC and for answering our audience questions. Some of them were pretty tough for you. So now our pediatric community of PSC patients and caregivers can move forward with the new school year armed with some really valuable information. And we'll be posting this recording on the conference page of our website for those who'd like to listen in again. And Dr. Mack just mentioned our programs for pediatric PSCers. So we have a great program, an annual conference, and the PSC patients who come to the conference form these incredible bonds. And they, by the end of the first day, they're like a little pack, and they are together 24/7 for the weekend. They're literally touching each other's shoulders, and it's wonderful the help they can provide each other. We also have a mentor program, both for parents and patients. And now we're doing some pediatric Zoom rooms too. So if you would like to know more about some of our programs, just get in touch with us at contact us at pscpartners.org. So thank you everyone for participating tonight. And just a few final reminders. Please go to our website and take the time to fill out our surveys for our October PFDD meeting, for our registry, and we also have one for patients who have had COVID and PSC to find out how they've done. These surveys are an easy way to help our entire community in our quest to find new therapies and an eventual cure for PSC. If you haven't yet joined our patient registry, now is the time. Please visit our COVID-19 page on our website for updated information on COVID and PSC. And we will definitely be very soon posting Dr. Boguniewicz's slide with all the resources they had today. Sign up for our mailing list so you can keep up to date on all of our programs. Watch for our upcoming conference webinars. Join our next Zoom room events, September 1st for PSC patients and October 6th for caregivers. Save the date for our virtual event, Making Our Voices Heard PFDD Forum on October 23rd. Feel free to send us any comments you have about this webinar or any suggestions for future webinars at contactus@pscpartners.org. Thank you again to our wonderful, wonderful speakers and our webinar series sponsors, University of Colorado Health and Children's Hospital Colorado, and our other corporate sponsors, Gilead, Mirum, Intercept, Alvarado, and Shio for their support. Please stay in touch. Thank you.